In this video, we'll be looking at how adverse drug reactions occur, why they might occur, and also how to classify them, and we'll also look at how they might be documented. So in this video, we're going to look at how adverse drug reactions are classified, why adverse drug reactions can occur, look at how you could document an adverse drug reaction, and outline some of the managing steps that might be undertaken when someone does experience an adverse drug reaction. So let's have a look at the impact of adverse drug reactions, and we'll have a look at some of the hospital statistics. So between 2015 and 2016, the number of adverse event-related hospital admissions was about 5%. Now, not all of these are drug-related, but 32% of these admissions were drug-related. So that's about 2 people in every 100 admissions to hospital are there because of an adverse drug reaction. When we have a look at the 2018 and 2019 data, we can break down and look at specific drug classes. So paracetamol, that classic one that everybody's taking for pain of some sort, over 6,000 people ended up in hospital because of probably an overdose of paracetamol. Some of those would have been intentional and some of those were accidental overdoses. Opioid admissions, close to 2,000 there, 800 non-steroidal anti-inflammatory drug admissions. And just to put this in context, let's have a look at those that are illicit drugs. So for the illicit drugs, there were 1,000 heroin admissions and 400 cannabis admissions. So you can see that regardless of whether they're illicit drugs or prescription drugs, we still have a major problem with adverse drug reactions and admissions to hospitals because of medications or drugs that the population are taking. So let's have a look at why adverse drug reactions occur at all. So we'll start by looking at the specificity of drugs and the selectivity of drugs and how they're interrelated. So to start with, specificity is drugs can target more than one receptor, and most drugs can generally do this. So for example, this drug is going to bind to an M3 receptor and a histamine 1 receptor, but it prefers generally the muscarinic receptor M3. Now, if we're now going to start talking about selectivity, that relates to dose or concentration specific binding. So at low doses, the muscarinic receptor is preferred, but at higher doses, the histamine receptor can now start being bound. And so therefore, if we're targeting the M3 receptor, and then we start increasing the dose, what we'll see is when that histamine receptor gets bound, maybe the person starts to get more drowsy than they used to be with that particular medication at higher doses, whereas they weren't drowsy at lower doses. Another thing that can occur is that with exposure to the drug, the receptor itself or the responsiveness to the drug can change. And so you can get up and down regulation of receptors. And so when you're using a drug like a beta antagonist, what can happen is you can get an upregulation of beta receptors. And so therefore, when you take the drug away suddenly, then the patient's noradrenaline, which would normally be binding to the beta-1 receptor, now has more beta-1 receptors to bind to. And so there will be an adverse drug reaction occurring when the patient actually stopped taking their medication. The other thing that can occur is that the same receptor can be expressed on different tissues or organs. So if we look at the parotid glands that are our salivary glands, they express the muscarinic 3 receptor, but M3 receptors are also expressed on the bladder. And so if you use a drug to treat incontinence in the bladder, you'll also cause the patient to have a dry mouth because you're targeting the same receptor in a different organ. And so that's one of the reasons why you'll get an adverse drug reaction. Adverse drug reactions can also occur because of our body's immune reaction against the drug. So for example, penicillin can be metabolized and bind to albumin. And then that can generate an immune response, and so our body starts to produce immunoglobulin E against it, and the person will have an anaphylactic reaction the next time they encounter penicillin. Other reasons for adverse drug reactions are drug interactions, and I'll talk about these in another video, but briefly, you can have pharmacodynamic ones where patients are taking two drugs that have the same side effect, and that will magnify the effects of that particular side effect. Or it could be pharmacokinetic, where one drug enhances the plasma concentration of another, and therefore there's a high concentration more likely to have side effects. Another interesting one is the nocebo effect. Now, this occurs when you believe that you're going to experience a side effect, and then you do. This is opposite to the placebo effect, which is usually a beneficial effect. So let's have a look at how pharmacogenomics can lead to side effect expression or experience for a patient. So I'll start by looking at how metabolism can change with genetic variation, and I'll use CYP2D6 and a particular allele, star 3, star 4, which is a frame shift and leads to poor expression or no expression of those proteins, and so you end up with a damaged protein being expressed. And the phenotype of these patients is they're referred to as poor metabolizers. So any drug that is metabolized by this enzyme series actually starts to accumulate. So in this case, for example, paroxetine, which is used to treat depression, starts to accumulate. So at a given dose, they will experience a higher level in their plasma and therefore a higher effect. And so therefore selectivity starts to wane because you're using high doses, therefore you're more likely to hit different receptors or targets. An alternate variation of this is the phenotype of an extensive metabolizer. So the example here is the CYP2D6 star 1 times 2, which means there's double expression, or star 2 times 3, which is a triple expression. Now, for paroxetine, this would mean that there was less drug exposure, so you'd probably have less side effects. But if you're using codeine, which is a prodrug, which is metabolized to a more active form like morphine, then you'll end up with higher exposure to the active metabolite, and so therefore the patient is more likely to experience side effects. Let's change the protein, and so let's have a look at the vitamin K epoxide reductase gene, which is the C1 type. Now, when there are genetic variations of this, what happens is the expression level changes, so mRNA changes can be seen. And so you actually end up with less expression, and so therefore the dose is different. So the average warfarin dose required for the AA or genotype is different to, or is higher than the AC and the CC. And so therefore there are more likely to be side effects if the dose isn't matched correctly to the genotype of the patient. Okay, so let's have a look at a number of different ways of classifying adverse drug reactions. So it could be the severity of the outcome. So it could be mild and just annoying and may not need any treatment. Or it may lead to the patient end up being hospitalized. Worst case scenario, getting worse, is that it leaves them with a permanent disability. If the patient happens to be pregnant, then it could actually affect the development of the child and lead to birth defects. That could be temporary, or they could be permanent. Or if the severity is so severe, it could actually kill the patient. Time-wise is another way you can look at adverse drug reactions. So they may occur when starting the medication. When starting the medication, they could be temporary, so they may disappear with continued use. Or they may be delayed, so they may not be there at the start, but they might appear after a week or a month. It could also occur that the adverse drug reaction occurs when they stop the medication. So immediately upon ceasing, then they start to experience a side effect for the next 1 or 2 weeks, or maybe longer. Or it could be a delayed adverse drug reaction. So it could be that they've stopped and then a month later or a year later then they experience the adverse drug reaction. And finally, on this slide, we're just looking at frequency. So using the AMH's frequency guide here, we're looking at adverse drug reactions that are common. So more than 1% of the population experience it. If it's infrequent, it's between 0.1 and 1%. And if it's a rare adverse drug reaction, then it's less than 0.1%. Now, be aware that after clinical trials, rare side effects or adverse drug reactions may not have been identified. And it's not until a greater population are exposed to the medication that you actually start to get enough numbers to confirm that this adverse drug reaction can occur with this drug. So as a health professional, part of your job is to be pharmacovigilant and to look out for these adverse drug reactions and report them when they do occur. So there is one system that was developed for monitoring adverse drug reactions for basically cancer chemotherapy. And so here it is. What they use is a grade 1 to 5, and each of the grades has a different presentation. So if we're looking at anemia, what they'll look at is hemoglobin concentrations. And so grade 1 is greater than 6.2 millimoles per litre. Grade 2 is that intermediate, and then grade 3 is less than 4.9. That's when you start to see a transfusion requirement. Grade 4 is life-threatening and urgent intervention is required. Then grade 5 is generally death for the patient once it gets to that level. And so this is a way that they were able to classify adverse drug reactions to give some idea of what the severity for the patient is and also the frequency of these. We don't always have this information, so it's good that this system actually exists so we can see how severe reactions are. Another example here is peripheral neuropathy. So this is where patients' sensations in the periphery are affected. So grade 1 is asymptomatic, so they don't really notice it. Grade 2 is moderate, and it can affect instrumental or basic activities of daily living. And so what that means is, does it affect their ability to use a phone, plan their meals, get around on their own, maybe catch a taxi or a bus or car, go and get the groceries, clean houses, pay bills. Those kind of things are instrumental activities of daily living. When it gets worse, it's more severe and it can affect self-care. So can they dress themselves, feed themselves, walk around? Can they go to the toilet by themselves? Can they bathe themselves? Those are the kind of self-care activities of daily living. So you can see this is another step up. And then grade 4 becomes life-threatening. But notice that there's no grade 5. So generally peripheral neuropathy doesn't kill the patient, but it does make life really hard. And so adverse drug reactions can have different effects, and they do fit into these grade systems slightly differently. So I've talked about the importance of documenting adverse drug reactions, particularly rare ones. So this is one mechanism of doing that. This is the IDOS DOT system, and I'll show you an example in the next slide. So first of all, we're going to have a look at the intrinsic factor, or identify the intrinsic factor, which is the drug or maybe the active metabolite. The intrinsic side is the target, so maybe what the receptor is or what the organ that is being affected might be. Its distribution often is where that target is. The outcome is what kind of signs might be measurable of the damage that the adverse drug reaction is causing. And the sequelae is the effect on the patient. So what is the symptoms that the patient will experience? The DOT side of things is, at what dose did this occur? Was it a low dose? Was it a therapeutic dose? Or was it a high dose? How does time factor into this? Is it acute? Is it delayed? Or is it a chronic exposure to the drug that leads to the adverse drug reaction? Susceptibility is there anything that makes a patient more likely to get this adverse drug reaction than not? So is there a genetic factor? Is it age? Was it a drug interaction that led to this? Now, sometimes you're not going to have all this information, but ideally, once you get all this information, it makes it much easier to predict and prevent future adverse drug reactions. So let's have a look at paracetamol toxicity. So if you want to pause the video at this stage, just read through it, and then I'll continue on and go through it and unpack it. All right, so you paused it. Now we're going to unpack it. So IDOS, the E, extrinsic, paracetamol. We can also refer to as NAPQI as being the intrinsic in this case, and this is a metabolite of the extrinsic factor. It's distributed to the liver, so that's where the main damage is being caused. The outcome for the patient, or the signs that are experienced, is glutathione depletion and hepatotoxicity. So it's actually killing the cells that make up the liver. Sequelae is death. Now, that's not all patients will go that far. It can be rescued if it's picked up early enough, and so you'll see N-acetylcysteine as the rescue therapy for paracetamol overdose. If we look at the DOT side of things, so the dose is with doses greater than 10 grams, so the normal dose is 4 grams or less. It's delayed, so the cytotoxicity to the liver takes time to build up before it becomes fatal. And people can be more susceptible to paracetamol toxicity if they're malnourished, they're dehydrated, or they've been taking cytochrome enzyme inducers, which will accelerate the metabolism of paracetamol. So when thinking about documenting an adverse drug reaction, one thing you probably would like to know is what's the probability that this drug led to this adverse drug reaction in this patient. So there is a scoring system that was developed by Naranjo, and I've just got it here. So you can see that each of the questions has a value to it. And if these are the yes values, there are also a set of no values as well, which can be positive and negative as well. And so the higher the score the patient gets or the event gets, the more likely it is that this drug caused this adverse drug reaction. So you can see at the top, has this been reported before? Did the adverse event occur when the patient was taking the drug? So if it occurred beforehand, then it's probably not the drug. So did the adverse drug reaction improve when the drug was discontinued? So as the drug gets eliminated from the body, then the adverse drug reaction you would expect to improve. So there's points for that one. Did the adverse reaction reappear on re-administration? So this is the classic retesting to see whether that drug causes that adverse drug reaction. Next question, did the adverse reaction reappear upon administration of a placebo? So this would rule out. How often this happens? Not really sure. Were there other possible causes for the reaction? So were they taking another drug? Was something else going on at that time that could have led to the same kind of symptoms being expressed? Was the drug detected in the blood or other fluids in toxic concentration? So this is looking at a dose dependency of the adverse drug reaction. The next question was the reaction worsened upon increasing the dose, or was the reaction lessened upon decreasing the dose? This kind of fits in with one of the previous questions about ceasing the drug. And then, did the patient have a similar reaction to the drug or a related agent in the past? So this is past exposure. So there are a lot of drugs that have a number of drugs within a class. So penicillin, so there's amoxicillin and benzylpenicillin. So, and there are a number. So if you've had an experience with a previous drug, will you get it with the same drug in the similar class? And then finally, was the adverse event confirmed by any other objective evidence? So was there any other kind of symptom measurements or signs that were measured that would also point to the same thing or confirm that adverse drug reaction? So the Therapeutic Goods Administration has a documentation form that you can see the link here. And so they will step you through a number of windows that will collect the data. So starting off with the demographics of the patient, moving on to identifying what the drug or vaccination that was given to the patient. They'll ask about time of the adverse drug reaction relative to the administration, what the consequence of the adverse drug reaction was, any other pertinent information that you think is important that might be related. So that could be susceptibility data, dosing, frequency, those kind of things, and further documentation or description of the event itself. And so by doing this documentation, what we're hoping to do is to prevent other patients experiencing the same adverse drug reaction. And so this is where there is a big focus on preventable adverse drug reactions. So this is one kind of tick box or question series that can be explored to see whether the adverse drug reaction could have been prevented. So first question, was the drug inappropriate for the patient's clinical condition? So this is about the indication. So this could happen with off-labeled use of a drug. So was the drug's dose, route or frequency appropriate for that particular scenario? Or was it inappropriate? So if it's inappropriate, then there's a higher risk that the adverse drug reaction is going to occur. Was monitoring undertaken or was it not undertaken? So if this is a narrow therapeutic drug and you want to know whether the dose you're giving will get the patient into the steady state concentration for that particular disease state, then that should be undertaken. And if it wasn't, why not? Was there a history of allergy? So this is about documenting allergy and making sure that that is confirmed and making sure that it is actually an allergy to prevent other drugs like it being given to the patient. So was there a drug interaction that exacerbated particularly the pharmacokinetic ones, or maybe even a pharmacodynamic one where you're getting additive adverse drug reactions? Was a toxic serum concentration detected? From question 3, was monitoring undertaken? So in this case, yes. Was a toxic serum concentration then detected from that? And therefore, the question is, how do we make sure that they don't go too high? And then, was compliance an issue? So was the patient not taking the medication and therefore the dose was increased to a point where when occasional use was enough to get them into the toxic range? Or was the patient actually taking more than they should have because they thought more was better and led to this adverse drug reaction from occurring? And that's where toxic serum concentrations can be monitored as well to confirm that. Okay, and finally, let's look at managing adverse drug reactions. So first step, can we remove the drug? If it's no longer required, get rid of it. If the adverse drug reaction is that severe, then it should just be stopped, and we'll work out what that drug is being used for later. Alternatively, step 2 is, can you alter the dose of the offending drug? So if the drug is still required, can we use a lower dose and avoid the adverse drug reaction? Now, this doesn't work if it's an allergic reaction because that usually occurs at a much lower dose. But note that it is possible, and there are desensitization protocols for a number of drugs. For example, penicillins, sulfamethoxazole, there are desensitization protocols that will allow treatment with those antibiotics later on. The amlodipine and gingival hyperplasia is an example where you could use a lower dose to prevent that adverse drug reaction from occurring. The third one is to replace the offending drug. So if the drug effect is still required, but you really can't continue using that drug, try something else. So for example, the ACE inhibitors, the angiotensin converting enzyme inhibitors, are known to cause a dry cough, but the angiotensin receptor blockers or antagonists are less likely to cause a cough. So swapping from an ACE to an ARB could solve that problem. Sometimes you'll need to treat the adverse drug reaction. This is generally not preferred. It can be done if the adverse drug reaction, if the offending drug has been removed and the patient is still experiencing adverse drug reaction, then treat the adverse drug reaction. Otherwise, what can happen is if you keep that drug and then use another drug to treat the side effects of the first drug, then the second drug is going to cause adverse drug reactions. And then if you go add a third drug to treat the adverse drug reactions of the second drug, you can see what's going to happen here is that the first is going to cause a second, third, fourth cascade. So that is generally avoided at all costs. So I've looked at different ways of classifying or documenting an adverse drug reaction. So we've looked at severity, impacts on patients, we've looked at dose, we've looked at why adverse drug reactions, was it pharmacokinetic, pharmacogenomic, those kind of reasons? Was it selectivity, specificity issues with the drug itself? We've looked at how to document it, we've looked at the IDOS dots, we've looked at the TGA reporting form, and we've looked at how to manage adverse drug reactions, literally by removing the offending drug, lowering dose, swapping to an alternative, or possibly treating the adverse drug reaction.